Hello, everyone. Today we'll be doing an analytical review of multiple descriptive categories of older adults and adults with disabilities in long-term services and supports in California.
Hello, my name is Savi Iyer.
My name is Angelica Barrios.
My name is Pramila Das.
My name is Araceli Hernandez.
And I'm Jenny Tran. In today's presentation, we'll be going over the introduction, our research question, research methods, analytical processes, our findings, and our conclusion. So first is our introduction. And as the U.S. population ages, more people will need long-term services and supports, or LTSS, for personal care, mobility, mental health support, and daily tasks. However, the current caregiver system faces many challenges like low wages or lack of training. Those receiving LTSS express dissatisfaction on various factors of the programs. And we are conducting an ongoing study at the UCLA Center for Health Policy Research, focusing on LTSS for older adults and adults with disabilities in Los Angeles to highlight other challenges. We're gathering qualitative data through interviews to understand their experiences with physical and/or mental difficulties, all while navigating LTSS programs. We have analyzed age, self-reported health conditions, and living arrangements to see how these factors affect LTSS experiences. And our research question is, how do experiences with long-term services and supports compare across various demographic categories?
Now we're going into research methods and analytical processes. So for the pre-interview, we distribute our recruitment flyers to our IRB-approved centers. Then we receive phone calls and proceed with the eligibility screening. If they're eligible, we proceed with the informed consent and schedule an interview, which is typically conducted by 2 of our team members. The questions tend to include experiences that the person may have with difficulties and/or needs for assistance with day-to-day activities, as well as background questions. Then for post-interview, we write a post-interview memo, and the interview recording is sent for transcription. Once the transcripts are received, they are coded according to our code book by at least 2 team members. Then they are gone for demographic analysis and post-coding memo. And then these coded transcripts are further analyzed by our graduate students through a program called Deduce. For analytical processes, the transcripts are coded according to these following categories, and then the transcripts are arranged by specific demographic categories, and then the codes are compared and contrasted.
Now moving on to the results section, where we'll be doing a cross-group and within-group analysis of 3 different categories. Our first descriptive category is age. We separated this to the under 60 and over 60 groups, where I'll be presenting common themes and different findings. Within the participants in the under 60 age group, none of the participants were fully satisfied with the support or services that they were receiving. They felt immense pressure to advocate for themselves and the services that they needed. They also report increasing difficulties in maintaining their social lives due to accessibility issues, stigma, and communication barriers. They also report mistrust in caregivers, transportation issues, unemployment, and financial instability. Within the participants in the over 60 age group, a common theme was the issue of undertrained caregivers and administrative staff. The shortage of workers and undertraining of these workers contribute to the need for more qualified and trained workers. Some suggested more protocols would ensure better training and screening, which is a solution to the issue. Most of the participants in this age group also reported having to self-advocate and independently navigate their own supports. Another commonality is financial difficulties such as concerns with cost of living, housing, and food that often stem from inability to qualify or be eligible for certain programs. Multiple participants in this age group report a need for inclusive services, technologies, and supports such as modifications in the home and attentive caregivers. This ties into a need for counseling and mental health support for older adults that is catered to their unique living experiences and needs. They express that there is a disconnect and lack of understanding with the younger generations.
The second descriptive category we analyzed was self-reported health conditions. This category was split into 3 groups: poor, fair, and good. We're still collecting data for the good category. I will now be presenting some common findings of the poor and fair subgroups. Within the participants who self-reported their health condition as poor, many participants expressed that they do not have enough time with their caregivers, and that leaves them without care at many periods during the day. Not only this, some expressed the need for a system reform that provides more training for caregivers so participants wouldn't have to train their caregivers themselves. Thus, their needs are not always met due to the inconsistency and instability of the caregiving system. Nonetheless, participants did also discuss the good and understanding relationships they have with their current caregivers. In addition, a lot of them are advocates for their health in order to ensure they and others are getting the services and other accommodations needed. Many of the participants have a greater need for stable and affordable housing that is accommodating to the high level and intensive needs that they have due to their disability. Within the participants who self-reported their health conditions as fair, many expressed financial difficulties in affording care on top of other expenses, including disability-specific equipment, and wish that care would be given more frequently and with proper training and specialization. In addition, issues concerning affordable housing was a common theme that was mentioned, where some experienced homelessness and were not able to have the accommodations for their disability. Outside the home, complaints concerned how many public areas lack disability accommodations, and thus the inaccessibility makes it harder for participants to navigate through social and recreational activities. A lot of participants discussed how advocacy was important. They needed to know how to navigate between resources in order to learn about their services and demand for their needs met. The need to advocate frustrated some participants, and for others, it was a positive and proud thing to do. Participants also mentioned how COVID-19 impacted them. Seemingly, there is a negative outcome on social life because of the restrictions put on connecting with friends and family, and others saw positives of the movement to work online because that accommodates their disability best.
The third descriptive category that we chose to analyze was living arrangements. So far, we've only considered one subsection within this category, which were participants who specified that they were not living alone, making this a within-group comparison. We expected these participants to express their care and daily needs being met more consistently than participants who stated that they were living alone due to a presumed added source of support. Participants living alone is a subsection that we hope to formally analyze in the near future. It is important to note that even though these participants stated that they did not live alone, it doesn't necessarily mean that the people that they live with contribute positively or help address their relevant needs. Here I've listed some of the major similarities within this group. For example, having positive caregiving experiences due to having a personal relationship to their caregiver and receiving informal support from loved ones. The majority of participants in this category reported being satisfied with the current support that they are receiving to meet their needs. It is a possibility that these reports can be attributed to the fact that most of these participants also mentioned possessing strong support from their family members and/or their social network.
Now moving on to our conclusions, through the analysis of our categories, similarities and differences emerged. Across three categories, participants reported having to self-advocate for their health needs. Participants with poor or prior health conditions both commonly reported dissatisfaction with current support, as well as difficulties in securing affordable housing. Regardless of age, participants reported having financial difficulties. Finally, in the younger age group below 60 years old, participants reported difficulties in maintaining a social life, with some participants relaying how COVID-19 and public health protocols heightened social challenges. Our participants' experiences show that there is a common theme of dissatisfaction in current supports through current LTSS programs. Dissatisfaction with LTSS programs can have significant implications, such as a decreased quality of life, adverse health consequences, additional financial burdens, and distrust of LTSS programs. In addition, the varied unmet needs of our participants show a strong need to improve service delivery through a multifaceted approach, such as improving training for caregivers and ensuring adequate funding. The future direction of our research will look to recruit and hear the experiences of individuals from more diverse backgrounds. We also hope to analyze other descriptive categories to see which themes emerge as more data gets collected. Eventually, our goal is to disseminate our research findings, influence policy surrounding long-term services and support programs to bridge disparities in service and enhance the program's quality.
These are the people and organizations we would like to acknowledge. Thank you.